morning, everybody. Thank you so much for being here, especially on day 3 of the Saturday, when your brains are probably very full and you're tired, and I appreciate you all coming. It really does just speak to your desire to learn and to want to learn more about preventing pressure injuries and helping free patients from the burden of wounds. It's my absolute pleasure this morning to bring you Rosemary Hill, who's going to share with us her journey for implementing pressure injury prevention in her facility and share with you a lot of her tips and tricks that she's done to help make that a successful and easier journey for herself and to hopefully help all of you. I'm not going to go into all the details, but all of you know Rosemary has been a nurse for over 35 years and has so much wisdom to share with us. And on a personal level, I can say absolutely every time I talk to her, I learn something new. So I really hope you all enjoy her talk and you learn something from her as well today. Thank you.
Thank you, Marianne. That's great. Now, I'm slightly hoarse this morning because, you see, I have a bit of a competitive spirit in me. And how many of you were at the gala last night? Yeah. And so our little team, at one point, we were in 3rd place. So I got a little, I was like, what? I'm in 3rd place. And then, of course, Happy Feet. And now let's just see. Our Happy Feet, are you here? Huh. Interesting. Happy Feet had, just saying. Anyway, okay, I've got my glass of water and we're good to go. She says. Now, I want to leave time also for questions. And probably the most important thing for me today, this morning, is I somehow want to communicate practical ways that you can go back to your place of work and take some of the suggestions, some of the tools. I'll make sure I leave you my email because sometimes it's overwhelming when we go back to our place of work and think, how do I do that? I want to uphold pressure injury prevention, but how do I do that? And sometimes going away with a little kit, a tool bag of ideas can be helpful. So if I forget to leave my email, remind me, because to me, most importantly, it's about sharing. And I learn so much when I come to conferences, and as we talked about yesterday, it's the interaction that we have, and we hear what's going on in different people's organization. All right, let's get going. And here are some of the objectives for the next little while that we're together. I guess I have to quickly go back to the basics and said, why is it we want to strive for pressure injury prevention? I want to go through a step-by-step practical approach. I want to identify and discuss. Sometimes there's barriers for implementation and some key components that would be helpful. Now, a year from now, I may talk to you about even more of my learnings and things that I'm doing differently. We're constantly learning, changing, and adjusting. So why is it, of course, we want to practice pressure injury prevention? Well, of course, it protects the patient. It enhances the quality of life in terms of avoiding suffering. We want to improve our healing and recovery in our patients. Of course, it reduces healthcare costs, and it meets our national healthcare standards. This morning, we were just chatting at breakfast, and one of the girls were talking about hospital accreditation and things that they have to have in place to meet the requirements. Of course, there's fabulous, we are blessed with all of the information that comes from both Wounds Canada and the RNAO related to recent research related to pressure injury prevention. So I put those up there just to remind you that there's some wonderful things to go back to. Interestingly enough, there are now the new international guidelines coming out. Now, they came out in 2025, but they came out split up with the prevention coming out, the prevention aspects of pressure injury prevention. So do you remember the other day the speaker mentioned soon coming out are the treatment aspects of pressure injury prevention coming out from the international guidelines. We hope to see that in November, but I have a feeling they'll be fully out there by 2026. I think that it's going to be what's unique about the international guidelines. It's going to be a living document. And so they'll be constantly updating information. So even right now, you can Google or go to your friend. I have this new friend, ChatGPT, and I go to him a lot. I don't know why he's a him, but I do. He's been very helpful. But you can go and you'll see what's already coming off the pages of decisions that have been made from the international, global groups internationally have come to terms with the research, the latest, to say what is best for the international guidelines. Let's quickly, giving you the background, remind ourselves of the prevalence. And indeed, and some of this data is still a little bit older, and we have to really get busy refreshing and putting new data around the prevalence of pressure injuries. But there's a quick slide. By the way, afterwards, I don't mind if people take photos of the slides, but if there's something afterwards you're interested in, just let me know, because as I say, more than ever, as we go through our years, it's about wanting to pass things on, right? It's wanting to share, to equip you. The cost, and this is sometimes a troubling factor. Do you know that the pressure injuries are one of the most expensive adverse events? So that's why all of us here in this room, ultimately we don't want patients suffering, but gosh, to your healthcare system, it's quite an expense. Look at the numbers for Ontario. The cost was specific to Ontario. And we're exceeding 26 billion in a 2019 report. So, and the next slide again, more facts around the increase in costs, and they're only going to go upwards when we look at the cost of pressure injuries. I'll give you a chance to read those. No more games the night before. The other thing that's really unique, and the international guidelines really spend some time recognizing the uniqueness of people of different skin tone colors and their vulnerability to pressure injuries. So, and I think that what happens is we don't recognize it. There's a delay in recognizing even a stage 1. So by the time they're going on with their pressure injury, it's more advanced. So I want to remind you of the key tenets of pressure injury prevention. You want to peel back, you want to take a peek, and you want to palpate. You want to have that look, touch, and feel. And also, particularly people of different skin tone colors, you want to compare either side. And sometimes their skin tone is a bit dry, and actually they encourage you, people of a different skin tone color, to actually moisten it, to clean it, to get a really clear perspective. Even lighting plays a role when it comes to people of different skin tone colors. And you obviously don't want to rub, but moisten, clean, and also you're going to have an attitude of inquiry. Ask about the pain and palpate. And so these are new recommendations coming in around people of different skin tone colors. By the way, later, I thought I'd wait till you all had your coffee and breakfast in. I am going to do some polling questions, but this one I don't have as a polling question, but I just want to see a hands up on this one. How many are you familiar now with new information that's coming out around people of different skin tone colors? We're seeing it in conferences, yes. So that is really good. And somehow we have to maybe settle on a scale related to the skin tone colors as we're looking at our patient. So those were some of the large groups of people who contributed to those international guidelines. I suppose you could ask yourself, why? Why do we have guidelines? But they help us build a bridge between what the research says and how we want to adopt that in our practice. There is a nice QR code which would take you to the living document of the International Pressure Injury Guidelines. And so when you go back to your place, it's often good when you're talking to people, managers, administrators, that you are speaking about upholding international guidelines. It's not just something you heard at a conference. So let's get down now to a bit of the nitty-gritty around how we're going to start to build in some prevention strategies. So before I do that, let's go to our app. Let's go to that polling time. And I'm curious, at your workplace, do you conduct prevalence assessment studies? Do you do a prevalence assessment study? And so let's see how this is going to work, Olena. Oh, okay. Olena at the end is going to capture pictures for me to see. Wow, you got quite a spread here. What interesting. And you know, I find these results not that surprising. It's very labor intensive to do a prevalence study, to organize the teams. So fascinating. Okay, in a way, this fits with some of the things that I want to share with you today, okay? So let me walk you through what we did at Lionsgate Hospital. So I want to make this easy for you. So I want to make sure you have these documents too, and you can tailor them for your place of work. So before the prevalence study, we send out a piece of paper to the patients the night before. We let them know that there's going to be a small team of people coming around just to check their skin. And this is how I put it. Check their skin, make sure they're in the right bed, and just overall make sure they're comfortable. That's the language I use when I start my prevalence study. So there's the letter all written up. The patients receive it the night before. Also, days ahead of time, we do a letter to the staff to let them know. But what I also did was go to a safety huddle. Nowadays, you really have to keep your messaging short. You really have to have that elevator speech handy. So we have a safety huddle at around 7:45 before the shifts begin. So a couple of days before the shifts begin, I said, oh, by the way, I'm going to be here Thursday morning. I'm going to be here with a couple of teams of people. And you know what the best time for us was? 6:30 in the morning. I want to tell you, we do our prevalence studies 6:30 to 7:30. And I got to tell you, both on the surgical floor and the medicine floor, we were done by 7:30. Okay? So I'm going to give you just sort of the practical tips. So we had 3 teams. We had an ends walk. I was the person, and there were 3 teams. We always had a nurse or specialized in wound care or a wound clinician who was the person who determined the staging of the pressure injury. We had a repositioner. Sometimes it was a care aide. Sometimes it was a nursing student. I loved that. The nursing students would volunteer to be part of this. And then we had a data recorder. So the data recorder, we had a face sheet where they collected the data. So we had our 3 teams, And there we were, bright, frisky, ready to rock and roll and go through. You know what we did too? We, at Lionsgate, we now have a brand new building. Gosh, and I mean this from my heart. If you end up coming to Vancouver, I would love to give you a tour of the Paul Meyer Tower. Paul Meyer Tower, an amazing, generous donor, $25 million. He was a plumber. I know some of you are thinking maybe it's good to go to the trades. And anyway, this plumber donated 25. And this is one of the latest hospitals in British Columbia, but it has some really cool features. So we did a prevalence study there, but we also went to the oldest building and the most intense floor, the medical floor, and also the cardiac floor. So we did studies in both Old Tower and New Tower, and we had our little team. There's our data sheet. Now, that data sheet, again, you can modify it to whatever you like, but this is what's worked for us, and we've been using it for a couple of years, okay? The first part of the data sheet, we do the day before. So we go around, we have Cerner, and so we collect data for that particular ward the night before. And then when the data recorder comes, literally, he's just collecting the data right there as we look at that patient, what bed they're on. Also, we included things like, do they have moisture-associated skin damage? How many layers of linen are they using? We also looked at their wheelchair. What's going on with their chair? Is there a special cushion? Now, I've seen many other data collection sheets. There's some really robust ones. We ended up trying to make this simple because there's the tabulating thereafter. So that's the chart review 24 hours before, collecting the data, collecting, did they do their Braden in that first 12 hours? And then that's really just the prevalence data we collected on the day of, the morning of, at 6:30. I think we're really interested because we're learning so much about the fact that it's not helpful to have many layers on that bed. So we literally count how many layers that the patient has. And then we itemize if there is some skin breakdown. But I want to tell you about something that's really important and not to be forgotten. Because when you do that prevalence study, you may make some discoveries. You may discover some pressure injuries, and you want to not get caught up on just having, I've just seen 36 bottoms, but rather you've got to remember that there were some people who had some injury and you want to follow up with them. And so there's a quick little cheat sheet where the people who did the data quickly go, oh yeah, bed 410, bed 2, there was a deep tissue injury. And so we need to do follow-up. So that's a nice little quick sheet to do right after your study. This latest round, when I did the prevalence study, was really interesting. It was in the New Tower, and it was about the third or fourth patient. And you know, I do feel, thankfully, we did it in August, so it was still, the light was starting to come in through the windows, so it wasn't as dark. And so I went to this lady. She was about my age, and this was on the surgical floor. And I said, oh, hi, I'm Rosemary. We're just coming in. We just want to check your skin and make sure you're comfortable. And she said, okay. And I said, did you get, and sometimes I'll say, especially if they're cognitive, I'll say, did you get the letter? She goes, yeah, I read the letter. And she said, that was good. And I went, oh, okay, good. So we finished checking her over. And I had my team with me. I had my repositioner and I had my data recorder. And so the three of us were just at the foot of her bed. And she said, you know, I just want to, can you just take a minute? I want to right now thank you all for what you're doing this morning. It didn't bother me that you were coming early because you see, my own family member had a pressure injury on her heel. And unfortunately, she died of it. So she said, what you're doing today, you have no idea how that really matters to me. And so you see, and our team listened, and we brought that back to the team, because we always have a little sharing after we do the prevalence study to say, well, there's some unique things that happened. But you see, for her, it really bolstered her in terms of the fact that this hospital really cared about people, their skin, and what mattered most. Now's where I want to talk to you about some of our tools that we have and that have been created for Vancouver Coastal Health. This guy is an OT, and he made this fabulous video. By the way, I shouldn't go much further without giving the praises of somebody by the name of Jeff Wang. Jeff Wang is a nurse specialized in wound ostomy continence, and he has a passion for creating education tools that are engaging for nurses, for family members, and he loves to do videos. So he did a video of this OT who does a short click video around repositioning. Again, these are all things you don't want to just throw everything at your staff, but you want to do it maybe in a timely fashion at a safety huddle. He has another beautiful little video on heels and pillows, really practical, where he does a little show and tell about pressure mapping. All right, time to do a little bit more polling here. Here's a really interesting question. Do you think your staff accurately stage pressure injuries? I'm curious. Now, I just threw out those random things like near me all the time, 75%, 60%. Okay, so let's see in our polling. Okay. Wow. All right, then you're going to be excited about this next tool. We had the same feeling. We felt that the staff aren't really sure how to stage pressure injuries. So you know what I decided to do? I decided to gather all of my photos of pressure injuries. And then I grouped them into stage 1 and stage 2. And then I made no, I didn't. Jeff made QR codes. So this particular poster, which we now have laminated, you can hit that QR code, and it's not just one picture of a stage 1, but it's a series of pictures. Because I don't know about you, but I have to see quite a few to kind of get into the rhythm. The same with stage 2, stage 3, stage 4, deep tissue injuries. But here's the coolest thing. If I come across another pressure injury, let's say next week, I hope not, but if I do, I'll send it to Jeff, he'll upload it, and that same QR code will still hold. We don't have to change the poster. So in the background, I am still giving Jeff more pictures, because I think a lot of us have trouble sometimes between the stage 2 and stage 3, and I really want to build that portfolio of examples. So, and then let's go to the top of the poster. The top of the poster has a little video, which we have permission from to put there, and it's around staging, but it's related to fruit. So again, everybody learns in a different way. And so we have that's just one poster that can highlight to people how to stage pressure injuries. And I think, to me, it's not only about staging, but it's also even just helping them recognize when they see that on a patient. So now you're wondering about the dog. Well, that's Lola. Yes, Lola is a pup. And so, pup pressure ulcer prevention. I know it's not pressure injury prevention, which is the correct terminology, but we've decided to make Lola our mascot. So we're making magnetic little devices Of course, if you're in the new tower, all the patients have a whiteboard. And there's going to be a little magnet of Lola. And that's going to be for people who have Bradens of less than 15. So that if a family member comes in and they see a cute picture of Lola, and they're thinking they know their mother doesn't have a dog, but we say, no, Lola is about our pup program. It's about prevention, so that they'll recognize our desire to be proactive. It loops them in. In the old building, we still have big boards with all the patient names. They too are going to have a picture of Lola. So I want to walk you through just the example. I thought I would just pick out stage 1, so that if you did take that QR code, these are some of the pressure injuries you're going to see. I didn't, for the sake of time, go through all of them for you today, but I thought I'll just go through, so you just get a myriad of pictures of stage 1. And so I think, what do you think about that poster? Do you think that's going to be helpful? Yeah? Okay, so I have this other idea. You remember I decided at the beginning of this conference to start an Instagram? And I know. I mean, here I am, over 60, dealing with Instagram, but it's kind of fun. So, Hills of Wound Care, I'm thinking, by the way, I do have a few followers. Maybe I'll get more today, but what do you think if I post that? And then it's just something for more people. Do you think, what do you think? Yes? Good idea? All right. You know, the Hills of Wound Healing, that's what it is. Because you know what? Gosh almighty, our wound healing does go with hills and valleys. And somehow I wanted the, although it's a bit long, I wanted the Instagram name to have something hopeful, like healing. Hills of Wound Healing, and my last name is Hill. Anyway, so here, we've got another, I'm going to call these practice enablers, okay? Practice enablers, that's what this is about. And so there's Lola, and it's just a little thing to remind people. So when we did one of the prevalence studies and we noticed, you know what, that Braden charting, some of the Braden charting was really good with one floor in the first 12 hours. The other floor, it was really good thereafter. But either way, we had to do some reminders about why is it we want to have people remember to score on Cerner and build interventions in. So there's another little question here for you. What percentage of your staff complete a risk assessment? Now, you may not have Braden. We have Braden, but go ahead and let's see what the audience says about that. Yeah, I think we're better. We're definitely better probably at doing Braden than identifying a staging of pressure injuries. That's really good. Okay, but you know, it's doing Braden, but for us, it's then saying, uh-oh, recognizing there's risk, and then choosing interventions that are going to be applicable and individualized to that patient. Are you going to have to pull in the dietitian and grab some expertise in terms of enhancing their nutrition? We also instituted prophylactic dressings, and that was another wonderful practice enabler. And so again, this QR code will help you in terms of the application and information around that as well. Okay? We miss Lola on that. I think we're going to somehow sneak Lola. She's got to be on all the practice enablers. But let's just do a quick reminder for those of you who might not be familiar, is how does it work? And so there have been numerous scientific studies related to the efficacy of how this works in terms of minimizing and redistributing shearing forces, redistributing pressure, reducing friction, maintaining optimal microclimate, and it's silicone-based. And at our place, we peel back, we peek, we palpate. I want to go back. Oh, that's just a teeny picture. On my slide, it was bigger. But the essence being that they did some mapping related to noticing the difference with the dressing versus without. I also, I talked about those international guidelines, and the 2025 that are coming out were built from the 2019 guidelines. Dr. Bunce made reference to those yesterday, and he had them up. And he was referring to the infection control practices. But those 2019 guidelines recommended the use of prophylactic dressings. So it's already been in the works that there is evidence supporting the use of prophylactic dressings as one aspect of pressure injury prevention. Our friend Dr. Dimitri Beekman also took that information and decided to do more studies related. And again, similar results coming out within 8, not just one hospital, but 8 Belgian hospitals. Excellent study. At Lionsgate, another enabler, that was our practice enabler just to help people, remind them the key features of when you are going to use a prophylactic dressing and you are going to put a P on it and you'll date it. Just some tips and tricks. You know what else we did? We, at our hospital, we have a staff lanyard, and that lanyard helps us get into the computer. It helps us get into all kinds of places, doors. The lanyard is essential. If you've forgotten your lanyard, you're really hooped that day at work. So, but we decided to put on the lanyard a pressure injury prevention little, just another reminder. And I know these things, after people see them a while, they'll, it gets, maybe it gets, hopefully it gets built right into their practice. The other thing we put on the lanyard on the other side of it was the Click web page. Remember we were talking about that? The CLWK, we made it a QR code so that people could go to that relatively easy on their lanyard. Most of our nurses do have their phones with them, or there is, of course, the work charge nurse phone as well. These are just more of the tools, and that's the Click website for those of you who might not be familiar. I'm going to just jump down another side street about proning patients. Now, I know that was something that was we were involved with during COVID, but we're still having some patients just recently. It wasn't COVID related, really difficulty with her respiratory status. And we got involved with proning her. Hey, I'm curious, how many of you in this room have ever watched somebody being proned? Yeah. It is not an easy task at all. Quite tricky, and you want to be careful when we are thinking of pressure injury prevention. So I took pictures with the permission of the staff in the ICU. And at one point, and it was very methodically done, if ever you've been part of proning a patient. And then even, I like the gal at the head said, no, I know there's 7 of us. I need one more person, because it was the CRT lines with the kidney stuff, the kidney stuff. I used to be an ICU nurse, but those days are gone. And the ICU physician was at the door, and so she stepped in. So there were actually 8 people turning that patient carefully. So we have some guidelines when it comes to proning patients. And again, these are things that are important. I know it doesn't happen often, but when it does happen, it's nice not to have something readily available that you can quickly look at. And here are again some features around applying prophylactic dressings related to when you're proning patients. I'm pleased to tell you that that patient is doing well and off the ventilator. I was fascinated, absolutely fascinated, because it looked rather bleak at the time of proning her and her respiratory status. So I went back the next morning at around 7 a.m. It was dramatic because I wanted to be there again for when they proned her back. Unbelievable how amazing how the proning has an aspect of improving her respiratory status, and how they were able to even pull her off some of the vasopressors. However, when we look at prophylactic dressings, I think I still want to remind you all that it's always important when it comes to pressure injury prevention. You still want to do your skin assessment. We have it on Cerner. You have to do that daily. You want to have your repositioning plan. It should be tailored for that particular person. And you want to make sure you're using the appropriate redistribution devices, especially when it comes to things like heels. So I'll take you to a few more enablers around heel repositioning, but also linens. Less is more. So we have a nice enabler around that with a quick information sheet showing if you have too many layers, you're going to be contributing to pressure injury development. We know there's a vulnerability with heels. Particularly, I find sometimes in the orthopedic patients with a fractured hip, where that side, that heel just sits there. But we have some Z-Flow pillows. We find those really helpful. Also for head repositioning. Anybody in here familiar with Z-Flow pillows or have Z-Flow pillows? You might want to check out the Mölnlycke booth. They're very, very helpful for repositioning. So just another tool to have available. One of the pieces of information that came out of the international guidelines was they're saying, you know what? Pillows are not quite enough. You need to go beyond pillows when it comes to repositioning heels. You need to actually consider if there is a real high risk and vulnerability to offloading boots or and things like that. So there's also different products, different prophylactic dressings I want you to consider for the vulnerable area. Now, I got another idea from the NPIP. There's a national conference in the States. It's called the NPIAP conference around pressure injury prevention. And this is unique. And this is actually being readily adopted in the United States. And it's called 4 Eyes Are Better Than 2. And it's all about, do you practice 4 eyes? Now, I have to say I got glasses when I was at an early age of 9 years old. And I remember the term 4 eyes. So it wasn't one that I readily grasped. However, this is a really unique concept that I am really warm to, and as is my manager and others, and we want to adopt. And it's about when a person is transferred, well, a couple of places. Let's say you have a patient in the emergency, and you're now going to transfer them to the ward or to high acuity. Before they leave the emergency department, 2 nurses, sometimes 2 RNs with some facilities, sometimes it's an RN and an LPN, or an RPN as you call it, must see the patient together to do that skin assessment, and then they document their signatures. So it's making sure your electronic documentation system has the capability of accepting 2 signatures on that skin assessment. Hey, just curious, is there anybody in the room who does this right now? Do I see anybody? 1. Okay, so you know what? If we were in the States, everybody's hand would be up. So, but again, their healthcare system is different. And so in terms of the financial side of things and costs and determining where the ulcer or injury occurred is critical. Otherwise, if the patient lands on the ward and it's discovered on the ward, that ward is responsible. So there's different impetus for having that 4 eyes assessment. But I think we too should have that passion for making sure there's been that thorough skin assessment where 2 people look together and sign. And so we're looking at implementing 4 eyes for pressure injury prevention. Where we're looking at doing it is within 8 hours of receiving the patient on the ward, that 2 of you will have signed off on the skin assessment. Wonder how doable do you think that is in your organization? Not so much. I wonder, is it because of the documentation system, the charting? Yeah, well, I'm going to have, okay, don't forget, there's going to be time at the microphone. So I'm trying to kind of open your mind to new ideas, and we may see this in the future, that we will be adopting this when it comes to pressure injury prevention. So I should obviously let you know some of the results of our work of doing these serial prevalence studies, and how indeed we found 16% fewer patients with happy as hospital-acquired pressure injuries, but also definitely 47% less wounds. We also noticed a reduction in moisture-associated skin damage. We did reduce layers, and I think the reducing of layers helped with our moisture and skin damage. And so, of course, as a result of putting enablers into practice, there was a reduction in pressure injuries. That's what it's all about. We hope these eye-catching pressure injury prevention approaches are going to reduce our numbers. So when we think now about all of these ideas related to pressure injury prevention for your place of work, what do you think? And now we're going to get a word cloud, I hope, coming up about, and yes, 1 word, 2 words, whatever. What do you think the barriers are at your place of work when it comes to pressure injury prevention programs? I think this will be interesting for the whole room. Time, yeah. Staffing. By the way, our groups of 3, the teams that we had the clinical resource nurse, clinical educator, and we had students. So it wasn't too bad when it came time to do those prevalence studies. It was a relatively easy thing to get our teams. Yeah. I wonder if we're missing the piece of presenting our current stats to management and administration about what we're experiencing when it comes to pressure injury and the costs. And I do believe that some of the information or research presented earlier, you could use that to pivot an interest in adopting some sort of pressure injury approach, some sort of bundle. Workload, yeah. Funding. Well, actually, it hasn't really cost us a huge amount because we're using the same people who attend the workday at that 6:30 to 7:30. So I will say from a cost perspective, depends how many tools you have in your workplace. Interesting. Very interesting. I thank you for all of those thoughts. So yeah, in summary, these are some of the things, but I think we need to start with the culture at your organization. Is it one that readily wants to step up and make a difference, and be the team that says, no, we want our patients to be comfortable, not suffering, be ambassadors of quality of care. Yeah, our resources are limited, and maybe some equipment. Maybe you'll have to look at some offloading devices and tools to assist. I'm hoping today that I just provided you with a number of tools that you don't have to create, that piece of the work, that workload has been taken away, and just hearing about a step-by-step approach. Sometimes we have to look, when we're looking at changing practice, our timing, and when is the right time. And maybe it's when your ward has just recently discovered a nasty deep tissue injury. And what we now are adopting is we go back to the safety huddle the next day. Do you know, in some places, as soon as that injury occurs, the clinical educator takes that, flies with it with the incident report, and then actually we hold a meeting within days later to say, how did this happen? Where was the gap? In other words, just as we would if there was a large narcotic or drug discrepancy, when we have a deep tissue injury, there should be that same degree of interest, attention to what was the missing piece. You know, one of our pieces that we discovered, here's an interesting thing. It was when we moved patients to x-ray on the slider board, and for some reason that they were staying on the slider board. Well, I guess it was just easy for everybody. And we found out that somebody got left on the slider board. So we adopted, this was a number of years ago, but those are the things where when you look at saying, how did this happen? How did this happen? What was it? Sometimes it was resistant to churning and pain management. So I encourage you, and then it was something like slider boards being left under patients. So have a look at why it's happening. Share with your safety huddle. But really, it is a team. I'd be so wrong if I didn't leave here to let you know it's a team of people you need. You can't be that one person, but you secure some people who are passionate, and it is so helpful when that team is interdisciplinary, when you have your OT, and you have, believe it or not, your dietitian. We know that our patients who are malnourished, they're suggesting even as many as 45% of our patients coming into a hospital are malnourished, and their preponderance or their proclivity to having a pressure injury much greater. So maybe you're going to have to involve that dietitian as well. Wouldn't it be fabulous to have a physician lead? I'm very fortunate that where we are, if I did see a patient and I did see a pressure injury, we all in our team, we notify the MRP, our most responsible physician. More often than not, they'll say, oh, I'm on the floor, I'll come. So I will say our physician engagement has been excellent. They want to see it, and they go, oh, wow, because they know it's now going to be an impact to the discharge planning. There's some of your equipment you may want to take a look at. I'm now running out of time, so I'm just going to mention, don't forget about looking at the pieces around education, and looking at the bedside in terms of redistribution and repositioning. And yes, moisture assessment is very much a piece of also in the aspect of pressure injury prevention. Nutrition, I touched on that as well. And hey, what do you think? We talk about 30 years, and we saw me, well, almost 40 years ago, and how I looked. But what do you think 30 years from now? Well, 30 years from now, will you be sitting at a conference and remembering this crazy lady who had this pictures of staging pressure injuries? And you're going to be talking about how you put things like that into practice 30 years ago, okay? So I challenge you to think about what you want to have the years ahead look at in your organization. Now, I've spoken to acute care, but these resources can be applied across the continuum. Okay, I'll stop. Okay. Any questions? I like the way I go, oh.
Hi, Rosemary. Excellent presentation. What a great program you have. I was wondering if you can speak about the role of photography, specifically around, because you're taking lots of pictures, and the concerns that I've faced with trying to get permission for photographs, even though like nobody's going to identify this little wound. But nonetheless, how's Vancouver
you know what?
addressed that whole, the consent
Karen, it's
and storage?
Yeah, we were both, Marianne and I, were at the conference, the NPIAP, in the States. I forget which state it was in. Texas? Texas. And that exact question came up. And, but by the way, for many of the hospitals, it's actually part of their policy that they take photos. Like, it's absolutely solid, built in, big time. So we haven't hit any issues per se. I always at the bedside, particularly if the person is cognitively intact, say, but you know what I use with the photo? I actually show it to them. I involve the patient and say, you know, here's where we're at, and I use it as a teaching tool. But we also, at the moment, we upload it into Cerner. So we do upload it into the patient's chart so that others are aware that we have a vulnerability here. So, but yeah, I know it's difficult, and you're not alone. And but even I have to admit, where there is quite a more of a litigious society in the States, it is deemed to be acceptable. I think that, yeah.
I'm just going to take one from one of the questions from the online people, because she had a few and she's very interested, and we have some similar questions. People are wanting to know, first of all, how often are you having your staff check underneath the dressing for the peel, peek, and palpate?
Q12.
Every shift?
Yeah, in the documentation in Cerner is such that it says it should be Q12 that you check, but there's an easy way to tick off once you peel back and put back. You literally, it's a tick when you get into Cerner.
And everyone also wants to know, how do they access your tools, is what they're asking online.
You know what? I'm thinking, what do you think? I'm liking
Your Instagram.
I'm Instagram for sure, but you know what I like? I like it because sometimes you have more questions. So I'm actually quite happy to give out my email address. I think it's about, because you may say, but what about this? What about that? You know, so if I gave you my email address, how about we do that? It's Rosemary, ROSEMARY .Hill, HILL, and I'm going to do at VCH, which is Vancouver Coastal Health.ca. Because I think I often find that it's sometimes you have more questions rather than less, and it may be not the tools, or you want to adjust, modify. So why not? It's about being in the present and giving as much information as I can, because it's a passion I have on many aspects. But really, when I think all of us have been in the room when our patient, and you've seen a nasty ulcer, and you think, how could we prevent this? How can we engage our staff? I do not want to be punitive, not at all. I want to come alongside that bedside nurse to help them. So, oh, I forgot to tell you, the other thing I'm going to do, October 16th, we're making a video. And the video is going to be me as a patient, and we're going to be talking about repositioning. Because literally they said, you know, our nurses are less than 12 months in terms of experience. And when we talk about repositioning, they're just not even sure. So I'm going to have a gown on, maybe a Foley catheter, briefs. So we're going to try and make it a little bit of a fun video about repositioning, so that will be another QR code. It won't be a Meryl Streep video, but it'll be a Rosemary Hill video. Okay. Got questions over here.
Hi, Rosemary. I'm going to challenge you. I had trouble answering a lot of your questions because I work in the community. Most of my patients are involved with home and community care in Ontario, and it's a very dispersed system. Prevention for many of these people is non-existent because they're maybe getting PSW support. There's not a nurse going in. They never get a Braden. Nobody ever thinks about it until a wound appears. So I'm thinking at a system level, how do we actually get a Braden done on these people on entry, flag them as high risk, get a nurse in, get the appropriate interventions in terms of prevention, engage the family, because those are the ones that are going to be the turning people. They're going to be part of the team. How do we give them the tools to make turning easy? God knows, I'm Googling slide sheets and removing numbers of linens and educating all the time, but I'm one person and I only see the people that have the problems. So I really think the hospital is maybe the tip of the iceberg, but that whole base underneath is where we need to go and think of our home and community care systems as an institution and how we actually implement these things within the community to prevent them coming in that way, have family and people engaged and preventing these things in the future, because the engaged family in the community is going to visit their family member in the hospital and say, oh, you're not doing that, and they're going to help pick it up as well. So
Yeah, I readily agree. So, what we're looking at, and we already have one, but I want to fine tune it a little bit, and it's a pamphlet for families. And so we're going to hopefully maybe brand the pamphlet with Lola. So again, I feel, what is Lola? Lola is an emblem to say, hey, we are interested in making sure that we're doing everything possible to avoid a pressure injury. On the North Shore, in the community, we have 2 NSWACs who oversee the patients there. And they're allotted a fair bit of time upon admission of a patient. And I do believe a risk assessment is done on admission. They have Pixelaire, and so they have to put that in. But sometimes, you know what I do? It seems overwhelming when it's a whole community, but I think a pamphlet for families is good, so that as a start, every nurse, first time going in, provides that pamphlet, because that pamphlet is as helpful to lay people as it is to that nurse, and she can speak to it. But I often find the area of vulnerability is the palliative patients. And so my first place would be to start off with the palliative patients. I'm just going random and thinking that hit the area where there's the highest degree of risk. But I think a pamphlet would be a start. But I like the leaders, my wound care clinicians in community, Neil and Vlad, to be the leaders to be upholding the prevention aspect. I don't know if that answers your questions, but stay tuned for a pamphlet that is also coming. As I say, we have one, but I'd like to tweak it a bit more and make it a bit more friendly. Yeah.
One more question over there. We close in 1 minute. We've got time for you.
Okay, very quickly, thank you so much. This was excellent, Rosemary, and you have new followers, just so you know.
What did you say? We missed.
Oh, sorry. I said thank you. This was excellent, and you have new followers, just so you know. The question I have, though, has to do with SEM scanning. So I saw that you had everything set up, the Braden scale. Do you also practice SEM scanning?
Haven't yet. I'm not saying there is something, I just haven't done that yet.
Okay, thank you.
I'm hearing good things about it, though. Yeah, that's what I'm hearing.
Are we done? Okay, sorry, Rebecca. We'll have you come talk to her afterwards. I'm sure Rosemary's welcome to having people come and ask her questions afterwards. So on behalf of Mölnlycke, I just want to thank Rosemary for helping everyone and share her pressure injury prevention knowledge.